Thank you guys very, very much for joining Lou and I on this Saturday morning on your off day. So if you have your coffee, great, because Lou and I both do. But so we're basically going to cover just the basics of like what it takes to treat pelvic health in sports med, and also the background that you should have in pelvic health if you ever want to treat sports medicine. Like Lou mentioned, this is an area not only that I'm like very passionate about now as a physical therapist, but also just as a former athlete. I feel like we like things were missed when I was an athlete. So my hope is that you at least take a little bit of the things that were missed when I was a student athlete and now can implement it forward for any student athletes or just athletes in general that you see in the future. Alrighty. So first and foremost, like why is this important? So, kind of big thing, obviously, is that this is an all genders issue. So a lot of the research that we talk about and a lot of the ideas that we talk about are disproportionately affecting our female athletes. However, don't forget that like your male athletes or your non-binary athletes or athletes of all genders, they have pelvic floors too, and they're incredibly important part of the core. But that all being said, as a clinician who works in women's health, we know that our professional opinion is sometimes ahead of the sports science and the research that is in this field. So, a lot of the things that we talk about, even just today, like we were saying as professionals for a while, and only now are we getting the evidence to back it up or are thinking about getting the evidence to back it up. Um, the big problem about pelvic health is unfortunately the stigma. We kind of forget that it's one of our primary core muscles, right? So we talk about the core being a massive preventative muscle when it comes to preventing injury and maintaining health throughout a long season. But we forget it exists because it's in a vulnerable area, and we don't like to sometimes ask the questions that are kind of vulnerable. As a result, right, and again, this is disproportionately affecting females. We can misdiagnose people, leading to longer recoveries or no recovery at all. And eventually, right, if you're constantly fighting against pain or constantly fighting against stigma that's associated with pelvic health, that's putting us more at risk for like athletes stepping away from their sport. Um, this is the thing I want to like drive home, I think, even like more than the other points, is that all sports physical therapists should be able to evaluate the pelvic floor. And that might be in terms of just like being able to ask screening questions, which we'll kind of go over in a little bit, or being able to treat it externally. You don't have to be an internally trained pelvic floor physical therapist to be able to recognize when this muscle is being dysfunctional, and as a result, be able to deal with the unique physical and emotional challenges that come along with being an athlete. And that's an athlete of all ages and all shapes and sizes. If you are pursuing an activity that is pushing your body to the limit, you are going to have unique physical and emotional challenges, and pelvic health kind of fits right into that. The other big thing, kind of like in that next bullet point, is that just like we're not talking a lot about pelvic health in our just general education of physical therapists, our athletes are also not getting pelvic health knowledge as part of their general understanding of their own body. A lot of people, when I first bring up the pelvic health, they go, "That's a muscle." And I'm like, yeah, that's a muscle, right? And it has all of these important functions, right? And, which are not limited to, or, not just like stability, not just like with the urinary like system, not just with the reproductive system, it's also involved in like lymphatic drainage and all and just keeping like blood flowing throughout the body and like I kind of mentioned, just like a vital part of our core. So being able to educate your athletes that yes, this is a muscle and it's a really, really important group of muscles. And then, right, our massive goal for today is to be able to connect your basic kind of MSK skills with pelvic health and women's health so that when you're going to evaluate an athlete, whether it's a female athlete, male athlete, non-binary athlete, athlete, period, that you can be able to make sure that you're checking this box and that it's not affecting their, injury or their day-to-day life. Whoop. So let's talk about like just general sex specific considerations. So the big one that has made the news lately, which if you're like a fan of women's soccer, they'll talk about it all the time. And that's how like just how disproportionately female athletes are being more affected by ACL injuries compared to male athletes. And so when it comes to ACL injuries, there's a kind of a couple things that we know. We know that a female, like an anatomically female pelvis is a different shape and size than an anatomically male pelvis, right? So that's first and foremost. The other thing is that we have these fun things called hormones, and they affect they sex-specific hormones, and they are going to affect um, female athletes' recovery, neuromuscular control, and tissue laxity differently in different genders. So, what does that mean? Well, like I said, the thing that's making news at the moment is the study that FIFA and I think it's Kingston University is going to put out is going to complete on how the menstrual cycle can affect ACL injuries. And I think this is really funny because when this first came out, I saw Megan Rapinoe and Sue Bird in their podcast talking about this. And so if you don't know, obviously Megan Rapinoe, world-class soccer star, Sue Bird, world-class basketball player, and then the two of them are just like a world-class couple. So um, they thought it was really, really funny that this was like a groundbreaking thing because both of them, I think, yeah, I know Megan Rapinoe's tore hers a couple times. And I think Sue Bird's also tore hers. Um, Both of them had been told by clinicians that being at a certain part of their menstrual cycle affected the reason or at least like came into play with when they tore their ACL. So that's something that like I ask like all of my athletes. I was like, hey, out of curiosity, where were you in your menstrual cycle when you tore your ACL? And for the majority of people I've asked, and I've also asked friends this because I've had friends tear their ACL as well. And majority of times they're in their luteal phase, so the second half of their menstrual cycle, where estrogen is decreased, and we know that there's a little bit more laxity in the joints because of tissue changes. So what does this mean? Well, couple things. Basically, like we've known that like the decrease in estrogen is going to change tissue structures for ages. We just don't have the research yet to back it up, which is hopefully what this FIFA study is going to do. Um, and so it's going to be interesting, I think, to see how we actually put this into play because at the moment we don't necessarily know how this is going to turn into a preventative tool. But I imagine that this is going to look a lot like starting to like cycle track our female athletes throughout a training cycle. I remember when I was in college that they would have us on like a 6 week training cycle, right? So you would like, start at, especially in the strength, like in the gym, you would start at like one strength and conditioning level. So kind of maybe like higher reps, lower weight. And then throughout that 6 weeks, those reps and the weight would change to help build like, strength and all the good things that we know weight training can do. I imagine that like with like menstrual like tracking the menstrual cycle, this is eventually going to look like taking that 6 week maybe training cycle and turning it into like a 4 week training cycle to kind of match with that. It's going to be hard, but I think if done right, we can actually prevent some of these like soft tissue injuries. Lou, I saw you're unmuted. Do you have a question?
Actually, I was going to chime in. It's interesting that you bring up this topic because when I was just at Notre Dame for a sports medicine conference, a lot of this was already being discussed, and it's becoming more of like a hopefully more of a mainstream thing. Because I know, I guess you just to give a little bit more background, the whole reason that we had this talk was because when I had gone up to Chicago to teach a dry needling course, that's how I met Adelaide, and we kind of bounce off one another in terms of where we're really missing as a profession, and it is enlightening to see that this is starting to become more of a factor. We need more of this information because we really need to do better as clinicians. And I think what you're talking about right now in regards to, tracking the cycle, making sure we're doing our due diligence and where do we strain, where do we not, this is so important for all clinicians.
Yeah. Yeah. And so I think this is why this is like one of the points that I know like we both wanted to bring up, just as like a sex specific consideration because, and I think like it's becoming more of this idea of like, okay, like I can sync my workouts with my cycle. I think, right, we're starting to have conversations of what that's going to look like. Because even I was talking about this the other day with someone,
Hmm.
and, um, someone's like said, well, like, what are you gonna do? Like, have them like not play when they're in like the luteal phase of their cycle? And I was like, no, you are never gonna convince an athlete that that's a good enough
Good
reason
luck.
to not play. Good luck is right. So, right, like this is like part of the discussions that like even like as newer clinicians you're gonna start to have is okay, we're not gonna take the athlete out of like a competitive experience, but how can we change the way that they're training so that we can decrease their risk even further? And like I said, I think like training with your cycle, right? Because I don't know if you've like the females like athletes that are or females that are on this call. I don't know if you ever tried like lifting the week before your period or the week of your period. And I remember in college, I was like, why is this weight not moving? Like why is the weight that I usually can do in my sleep like just not getting off the ground? And why I think also just from like a mental health perspective, like why are we forcing people to do the same weights that they're doing in certain phases of their cycle, in other phases of your cycle? So
Hmm.
I think, right, like cycle tracking is going to eventually be one of those things. I think also one of the things that I drive home when I see my pelvic patients, but also when I've like seen, a lot of like orthopedic patients in the past, is that I'm teaching them to load differently based on their anatomy. For example, if I love a good like step down. I think it's really functional. I think like, you know, if you can't go down the stairs with good control, then, why am I going to get you to jump? Why am I going to get you to run? Why am I going to get you to do anything? But I cue it differently depending on whether they have like male or female anatomy. Um, so my male patients, I tell them you want to be over your toes as you lower down, but you don't want to be over your big toe. My female athletes, I'm cueing them over their big toe. Why? Because the angle of their pelvis is different. And I think like we run into problems as PTs and as strength and conditioning coaches. And this kind of goes into that point about like patellofemoral pain, and sometimes even like stress fractures, like especially those like distal stress fractures that can be like a force management problem.
Hmm.
If we're teaching, if we're teaching our female athletes to load their joints and their body at the same angle, like biomechanically, that we're teaching our male athletes, well, why? Is my question. Because, right, like We know that when we load a joint, we need hip flexion, internal rotation, and adduction.
Hmm.
If we to have that like successfully be balanced in a wider pelvis, which is what like a female athlete will have, you're gonna need, and to get that center of weight more over their body during a single leg stance, you're going to need more adduction. Here's the problem though, is that we know excessive valgus is going to lead to an increase in ACL injuries. We don't really know what excessive valgus means, by the way. We haven't found a measurement that that correlates to. But I think that if we don't train into valgus when we're loading, which is like that kind of classic loading response, then
Hmm.
again we're going to put ourselves at more at risk for injury because we're never going to train in that field. And so again, that's why you know, turn off. Sometimes it's important to turn off your informatics brain of like, okay, like I know that like when this motion happens, that like this comes at this degree angle and this, comes at like the knee comes at this degree angle and the hip comes at this degree angle, and
Hmm.
kind of just turn on your like, let me watch this person and see how it looks brain, which we're also trained to do as PTs. And I think just like over the years, I've found that like unless like we're getting more adduction and more controlled adduction and internal rotation, and flexion of the hip and the knee with these loading exercises, in our female athletes, like the better they're looking and the more control that they have. And so, right, like I said, turn off that brain because sometimes, like I said earlier, sometimes the research hasn't caught up with us yet, right? Like I said, we don't even know what excessive valgus means yet. We just know that like if that motion happens out of control, that can put us at increased risk for injuries. Um, so yeah, that's my rant on loading athletes.
Uh,
That and like what like why are you jumping? You can't do a single leg squat yet. So then like the big other thing that like kind of like we touch upon on this slide, right, is REDS. And I think Lou, I think we had this conversation actually because this is a conversation I had had just before I met you.
Correct.
I I was talking with a sports medicine clinician, so someone who sees primarily student athletes,
Hmm.
and I was trying to teach him like what athletes might be more at risk for pelvic floor dysfunction. So REDS is relative energy deficiency in sports. It is the updated female athlete triad because again, it's an all gender issue. And this particular clinician had no idea what I was talking about when I was saying REDS is a comorbidity with pelvic floor dysfunction. Um, as a former athlete, I was shocked, right? I was, I, I remember talking to my husband, who's also a PT, and saying, I was like, this is someone who treats primarily student athletes, and he is not aware of the biggest yellow flag in the game. I think, like, if I could, again, if you can take one thing from this, just put reds in the back of your mind.
This is the discussion that like set this entire call up because it was
This
oh,
right. This was like, and I remember going to Lou and I go, Lou, you like know what Reds is, right? Like I'm not just in this like, dark hole of like, very specific, like female specific things. Um, he's like, no, 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 I know what Reds is. So, anyways, let's talk about it a little bit more because I think like it's one thing to know the term and it's another thing to be able to be on the lookout for it. So if you remember kind of the like the old female athlete triad triangle, right? It's like at the junction. I'm gonna even just like pull up a photo here for myself just to remind myself. So, it's at the junction of like basically like high energy expenditure. low energy availability. A lot of times in athletes, believe it or not, it's because of disordered eating and less because and less because that they're training a lot, which they are. Don't get me wrong, they're expending a lot of energy. But again, if we're talking about yellow flags in sports, there is a lot of pressure of athletes of all sports to look a certain way. And that, and even there's pressure from like coaches that if you look like this, you're gonna perform better. Again, you talk about like kind of personal anecdotes, and I was talking with an old teammate about this literally just the other day. Um, so when I first started off at university as a D1 athlete, I was initially like a multi in track and field, meaning I did everything. There wasn't an event we didn't touch, except maybe pole vault, but I don't really need to fly over a bar. Um, but anyways, so she and I were talking and we remembered a specific instance right at the beginning of our careers where our coach pointed at the two of us, looked at the rest of our teammates, and told them, by the way, these were all female teammates, told them that they needed to look more like my teammate and I because were in a slightly more like muscly body, right? So take yourself out of your PT mindset for a little bit and just put on like your human cap. That's crazy, right? That's crazy. Why are we telling people like why? And don't get me wrong, the athletes that he were looking at were incredible athletes, right? When you get to that level of a competition, these people are not like rolling off the street, like cross training using track, so to speak. Like they were outperforming me in like several events, right? But yeah, this like specific coach looked at my teammate and I and was like, "Yeah, you need to look more like that." This is not like I am not the only athlete who's had like a story like this. In fact, you'll be hard pressed to find an athlete, especially a female athlete, unfortunately, that hasn't had a story like this.
Jeez.
So, yeah, go ahead, Blue. I can tell you're like dying to say something.
No, that's oh man. I guess all I can really say about that is just do better. That's atrocious. But it's important to note that like a lot of these issues are not just physical. Like there's a huge psychological component to it. The nutritional aspect is, I mean, if you're in a more of like a rural area, like ha th those go untouched for years. And that's why like if we can make clinicians better and we can make people more aware of these types of um, I guess this information. We need to be more aware of this as a whole.
Yeah. Yeah. I mean, I also like another story that like I think about when I always think about Reds is the story of a there was like a nationally ranked high school runner named Mary Kane.
Hmm.
And she basically right out of high school went to go run for Nike in Oregon, which is like the big running team. And keep in mind, like she was a like world-class athlete in high school, right? So like she was top of her game. As soon as she got to Nike, she was already small. They made her cut more weight in order to improve her performance. Which brings me to like the next side of that triangle, especially with like female athletes, which is like loss of a menstrual cycle. It's a it's an uncomfortable question, right? But if you're getting an athlete or athlete, I would say an athlete of any kind, like check in with like what their eating is, right? Just like have a question, say, hey, like, are you having like 3 meals a day? Like, what is your like recovery looking like? Um, that is an even more important if you're coming in with an athlete with a stress fracture, especially like those proximal stress fractures that are like more linked to like low energy availability. And this is why like RED always ends up being a comorbidity of pelvic floor dysfunction, right? Because we're in the middle of that triangle. So, right, as PTs, we see people with stress fractures. As pelvic floor therapists, I ask a lot of questions about eating and nutrition, especially if they're coming to me with constipation, which a lot of your athletes are probably constipated, right? And then, right, in that kind of like in that third block, like loss of menstrual cycle, right? That's the pelvic floor therapist at me. I'm always asking, like, hey, what's your cycle looking like? Like, is there any pain with that cycle? So, right, even if you, this is why, like, even if you never like treat a pelvic floor specific patient in your entire life, this is why it's important to ask the same questions as a pelvic floor therapist for yellow flags like this. And especially if you work in kind of a very athlete dominant population. Um, so yeah, those are kind of my big sex specific points. I think like oh, Lou, we have a raised hand. I don't know if you saw that.
Yeah, Danielle, go ahead and unmute yourself. Ask your question.
Thanks. I was just wondering. So, you're talking about noticing the different signs of reds and, asking questions about like painful cycle and amenorrhea and things like that. And I'm just wondering, you might talk about this later. So, sorry if I'm like jumping
Oh,
ahead,
you're
but
good.
You're
what
good.
is your role like as a PT if you start to recognize those signs and like you're suspecting someone of maybe having this issue? Are you just
Mhm.
immediately referring to like dietitian or sports med, or like how do your interventions look different? Just kind of like on a practical day-to-day basis.
Yeah, I love this question. We're gonna go over a little bit with the case study, but I also don't mind driving this point home a couple of times. So, if I were to get an athlete, so say like, I get like an athlete with a stress fracture, I'm immediately, I mean, in my brain, this is like immediate. I'm immediately asking them about their nutritional habits. And then I'm immediately like asking if they're a female athlete, right? Asking them about their menstrual cycle. I'm also asking, like, is this the first stress fracture you've had? Right? Because a lot of times these people, like, they'll have a couple, right? It's very rare, especially like I said, with those like proximal stress fractures that they only get one because they're more based on this low energy availability than the force, like the force production or improper force production. So it depends on like first of all your comfort level. So, if that's your comfort level of like, hey, I asked my questions and they're saying yes, then it's a matter of being like, oh, all right, like here's a few like registered dietitians that I know of that like specialize in sports. Do you want to talk to them? You know, if they're not already talking to like a dietitian to begin with. And then, hey, like, do you have a therapist? Are you talking with the therapist about your relationship with food? Um, here are a few therapists that I keep in my back pocket kind of thing. The other thing I would recommend is looping in the other members of your sports med team. So, for example, if it was referred to you by a physician, I would let them know about the kind of yellow flags that you're seeing. I would let AT know if they have an athletic trainer. And then I would also let any sort of coaches know. Get everyone kind of on the same page and say, hey, listen, like I think, and this goes back to like another point that I see a lot in sports that we don't do a great job in sports med, which is knowing the difference between psychological readiness and physical readiness, right? So if that stress fracture is fully healed, they might be physiologically ready to return to sport. But if they're still, showing, you're talking to like the registered dietitian and they're still showing signs of disordered eating, or they, still haven't like had a menstrual cycle returned, then they're not psychologically ready. And I think you should feel empowered to say, hey, I don't think they're ready to return to sport because of XYZ. And then kind of the last thing that you asked, I think, was like, does that change my, like, how I treat the patient? And I mean, like, yes and no. I mean, like, I think in this situation, I'm having conversations with them, like, normalizing the fact that like hot like hey, you've lost your menstrual cycle, like we're not eating as much as I would love us to, like, and kind of keep bringing it up, because I think the thing about sports med is that these things are sometimes mentioned in passing, but no one like drives them home with a specific patient. So with a patient like that, I would continue to rehab while continuing to have those conversations. And on the flip side, I would limit their force, like their high impact activities, maybe a little bit longer than if you know, than like normal bone and tissue healing, probably. Knowing that they're probably not getting the nutrition that they need for normal bone and tissue healing. Does that answer your question, Danielle?
Yes, thank you very much. That's the force, the high impact exercise was a big thing that I was wondering. So thank you for hitting on that at the end.
Yeah, of course. All right. All right. Cody, feel free to unmute.
Thank you for putting this on, Adelaide. But I was just wondering, off of that, you were talking about the yellow flags and communicating them to like the sports med team.
Sure.
Um, I'm assuming that's within like a university setting when you're talking to like sport coaches. But I was wondering in like the private setting, if it's like a junior high or high school kid, kind of how you
Mhm.
go about that. Like maintaining the confidentiality of the athlete and the patient, but still like doing it in a safe manner.
Yeah, absolutely. So, yeah, so I think that's a great question. I know like still at the high school setting, a lot of times like an AT is involved, but let's say for the sake of this that like no one else is involved. Right, which I think is kind of like what you're getting at. Um, so say like direct access, this patient walks into you off the street, you're suspecting maybe like a stress fracture, or you've asked these questions and then things aren't lining up, you're noticing these yellow flags. I think like I think in this situation it's tricky because right, you don't want to like obviously like start blabbing to their like AT if they haven't kind of like given you permission to. But I think you should first and foremost, empower the athlete to have these conversations with their medical providers. If for whatever reason you feel like they're not able to have those conversations, that's when, you would reach out with them. And then if they're also the other thing consideration to have if they're like junior high or high school is like bring parent into the conversation, right? Like at this point, they're still a minor. So again, empower the parent to have this conversation, empower the athlete to have these conversations. If for whatever reason, which is sometimes the case, especially with like disordered eating, you think that like the parent might be, you know, at least like sometimes like the parent will be the one driving the hey, you need to cut weight conversation. So if you think you need to, again, bypass that, you're empowering the athlete to have these conversations and giving them the resources to reach out to. So therefore, you're not like blabbing to your colleague, even if you work with this registered dietitian all the time, or you work with this AT all the time. That way, you're not like, breaking that HIPAA or confidentiality. And then, right, last case scenario is at the end of the day, it is our job to keep our patients safe, right? And so asking then them permission, can I go talk to this person about you? Can I release information, and making sure that they're signing them and their parents are signing a release form so you can talk to the other clinician, especially if they've started to establish care with this other provider. It's a tricky one, right? Because there's a lot of, especially with like I said, with the junior high and the high school, there's like a lot of kind of players at play. I think at the end of the day, like trust your gut, and right at the end of the day, also you need to protect your athlete. And also if there's a stress fracture involved, you should have a physician looped in anyway, hopefully. Does that answer your question, Cody?
Yeah, that makes total sense. Thank you.
Yeah, you're welcome. All right, so we're gonna switch gears a little bit to my wheelhouse. So a little bit more from general sports med to pelvic health in athletic populations. Um, so this is to me where like as much as we struggle to ask about those yellow flag questions sometimes, as much as we struggle to, make sure that like we're talking about like menstrual cycles, sometimes those are easier than asking a patient if they have pain during sex or if they have pain with urination or bowel movement or if they have incontinence. Um, so, right, pelvic floor dysfunction, I think it's, again, we do a really bad job reporting this and research because if you look at the research, especially in female athletes, it could be high as like 80% of athletes have pelvic floor dysfunction. And then like some studies are going to find that it's like 10%. And I think the biggest reason why there's such a disparity in those numbers is because we have like a hard time, or sometimes people have a hard time reporting these things. One, because they've been normalized within their sport, and two, because of the shame that's associated with them. So the big ones that like you can see, right, are like we talk about like urinary or fecal incontinence, like I said, constipation, um, because either because of the like poor nutritional status and or because of the impact. Um, Prolapse, which if you guys like aren't aware of, is basically like a decrease in the support of all those pelvic organs. So think reproductive organs, think bladder, think rectum, leading to those structures moving into either like the vaginal canal, if they're a female athlete, or moving like down through the rectum, or even like down, like the bladder down through the urethra. So basically, like they all sound kind of like scary because, right, like why is my rectum moving through part of my rectum moving through my rectum? But at the end of the day, it basically in pelvic floor terms, we call it like just a support dysfunction. Because again, that's one of the big roles of the pelvic floor is to support the organs of the pelvis. And if we're not doing that, either because of like strength or um like uh concerns such as like hypermobility or impaired like tissue in that area, you add impact to that and it can lead to like more injuries of those structures. But like, right, it doesn't just like stop there when it comes to like urinary incontinence and fecal incontinence. The big reason why I find that this population is at risk for pelvic floor dysfunction is kind of a couple of reasons. The first one is that this population is entirely obsessed with their abdominal muscles. They, and I think part of that again is the whole like aesthetic of like I am an athlete, I should have a six pack. And the other area of they've been told that their core is going to prevent any and all injuries, and therefore if they train their core, they're not going to get injured, in simple terms. As a result, you end up with this like soda can pressure management situation, meaning that they're overengaging their abdominals and underengaging their pelvic floor. So if you can think about it, your pelvic floor is going to sit at the base of the abdomen. Your back's going to be here, your abs are going to be here, and then your diaphragm's going to close off the system at the top. If one side of the system is constantly being trained or overtrained to the point where there's a decrease in mobility there, that pressure's got to go somewhere, especially if then we add more pressure with high impact activities. And because gravity pulls down, a lot of times it's a downward pressure, and that's what leads to the pelvic floor dysfunction. Because it's not like you're in the strength room, the weight room, and your strength and conditioning coach is saying, hey, when you engage your abdominals, you should also squeeze your pelvic floor. I would pay good money to see a strength and conditioning coach someone through a Kegel. Um, one, because I think it'd be so awesome, and two, because I just haven't seen it happen yet. Um, but basically, right, your pelvic floor should engage anytime your abdominals engage. So if we kind of walk through a squat as kind of like a simple motion, as you go down, right, and your abs are more relaxed, the pelvic floor should be relaxed. And as you stand up, your pelvic floor should be engaged as well as your abdominals so that that pressure system has support from two sides, right? We talk about the third side, which is your spine. We need good, stable spines for good, healthy pelvic floor, but we can't like change the spinal column as much as we can change, say, the pelvic floor or the abdomen. The other structure that we can change is the diaphragm. And again, we're really bad at this. The amount of people that I have to teach how to breathe is astronomical. And the big reason for this is that we live in a society that, one, overemphasizes a Valsalva maneuver, so that closed glottis, in order to increase the pressure of the abdominal cavity for stability. And two, we live in a society where the term suck in is very common, basically. Um, and the big thing that I run into with my pelvic floor patients is that are they are taught that abs engage as you inhale, which is totally against your natural kind of biomechanics. Luz looks distraught, just me like saying that. Um,
I've met
the,
more
the
Olympic weightlifters who have been taught that than I would care to mention. It's so
yeah,
infuriating.
it's so infuriating. Yeah, it does especially with the Valsalva, it does create a sense of stability. And there is like some people out there that say that you can't lift beyond 80% of your max without Valsalvaing, which I would disagree that that's not your max, right? If
Mhm.
that you're having to have a compensatory strategy while you lift, is that truly your max? Also, if you're not engaging your muscles, how is that how is that your max?
Mhm.
So, right, the important thing to know is that the coordination of those muscles should be as you inhale, your pelvic floor and your abdomen relax, and as you exhale, your pelvic floor and your abdomen should engage. So if we go back to the squat, and you've squatted down, everything should be relaxed. You shouldn't be valsalvating. You shouldn't be holding your breath, right? So you're inhaling on the way down, and on the way up, that's when you're exhaling. You're squeezing your pelvic floor and you're using your abs to maintain your stability of your spine. Again, if we talk about like drive home points, don't hold your breath while lifting. One, because it raises like your blood pressure. Like we don't need like people like passing out while they're lifting. Two, that mismanagement of intra-abdominal pressure. So like that holding our breath while engaging or while trying to engage your abs, while trying to, that's what can lead to like incontinence, and prolapse and like im impaired pressure on that pelvic floor. I think like a lot of us have seen the like heavy weightlifters who basically leak when they max out, and everyone's like, oh, like you couldn't lift that weight, like don't shame her, or like don't shame him. It's usually a female, obviously. um but yeah, like don't and one time I got like sent a video, and like someone was like, well, what's going on here? Like, should they be leaking? And I'm like, no, no, they shouldn't, right? Because if they're truly like bringing all their muscles to the table for like optimal stability, they're not holding their breath and they're not having a lot of downward pressure. Um, and, Lou and I can both tell you that improved core and pelvic floor activation can also help your performance, right? It's like basically like saying, hey, I'm gonna lift my max, but I'm gonna do it without using my muscles, right? I'm gonna forget that like a couple of my muscles, important muscles, by the way, don't exist. And that's how I'm gonna like lift my max just by like generating pressure. And or you could hit your max in like a deadlift, a squat, a bench with all your muscles to the table, and you're not leaking, and you're not raising your blood pressure, and you're not putting yourself at risk for like prolapse and pelvic floor dysfunction. Um, so again, and this goes for my orthopedic patients, I was like, I do not let anyone lift anything while holding their breath. In fact, like if patients learn anything from me, it's breathe, breathe, please. I don't need you passing out in my clinic. That's a lot of paperwork. Um, so, right, let's talk a little bit about like screening for pelvic floor dysfunction. So there is a measure, and I didn't put it on here, of course, because that would make too much sense. But there is a measure called the Cosian pelvic floor screening tool. I like encourage a lot of like, any clinician to at least like know what it is so that they know the questions that are on there. A lot of times it's like, do you lose like urine or stool beyond your control? Do you ever like, one of the big ones actually on there is, have you ever landed on your tailbone? Right, which the amount of high level athletes who have landed on their tailbone at least once, pretty high. Pretty high. That's, I don't know if you haven't fallen over while playing in impact sports, were you even doing it right, is my question.
Mhm.
But the reason why tailbone injuries are on that list, not only because it's in that area, but two, because a lot of these muscles attach to the tailbone. So your pelvic floor muscles, like including like your levator ani and your like periurethral muscles, so the muscles that control like urination, and like your rectal muscles, they kind of all come to it like a head almost at the tip of the tailbone. So if there's dysfunction of the tailbone because of an old injury, there is more likely to be dysfunction um, in those muscles as well.
Mhm.
Um,
I just put a little link in the chat for everybody if you want to go check a look at that screening protocol. Go ahead and take a look.
yeah. So it's like, and it's really easy. And it's like, I think like having something like that bridges the gap between um like being uncomfortable asking these questions and starting to ask these questions. Because sometimes people are like, I don't know what questions to ask. Like I know that like, you know, if you have pain down there, like that's probably a pelvic floor problem. And I know if you're leaking, that's probably a pelvic floor problem. Um, but that sometimes they don't know how to ask those questions. But like using a screening tool like the Cosian is helpful because it gives you the questions. You could literally pull that out and start, staring at the piece of paper and ask those questions as they're worded there. As you get more comfortable, these questions are going to be easier. So we've talked about incontinence, we've talked about prolapse, we've talked a little bit about like constipation. Basically, like if these muscles are not mobile, like stool's not coming out, right? Or like if the nutritional needs aren't there, that's not going to help your constipation either. I think the big thing, and probably sometimes even the most vulnerable thing, even though it's the thing we're used to asking questions about, is pelvic pain. So kind of two veins of pelvic pain. There's the pelvic pain that's coming from like normal anatomic structures that we're used to dealing with as general clinicians. And then there's the pelvic pain that really only pelvic floor therapists are used to asking questions about. So, that kind of pelvic pain is more likely those questions about like, you know, any pain, like, do you get pain with insertional sex? Do you get pain with like, say, vaginal medical examinations or rectal like medical examinations? Um, are you able to, if you're female, are you able to put in a tampon to be able to compete when you're on your period? Because I don't know if you've noticed, but female athlete uniforms are not known for being um, the most like they're not they don't cover a lot of skin sometimes is kind of the best way to say it. So for example, if like a female athlete is on their period, they can't put in a tampon. Their only real option is to use like a pad. And in some cases you can't do that because you're, I don't know, in water or because your uniform really won't allow it without it being like incredibly visible, right? So sometimes like noticing that like an athlete isn't competing like once a month around their menstrual cycle. One, you can ask about like, just general like pain associated with their menstrual cycle. But two, like, is it because they like simply cannot put a tampon in because these muscles are so restricted? So there's those kind of that kind of pain specific to the pelvic floor muscles themselves. And then there's the chronic low back pain, chronic hip pain, SIJ pain, tailbone pain, all of those things. Um, this was like another conversation I had with a sports med colleague of mine where um, I was like, well, what's your thoughts on like SIJ pain? Well, I don't really think it's like a thing outside of like pregnant women. I was like, oh, okay, that's a choice. And I know that this is like it's been brought to my attention since then that like this is kind of, I guess, like a thing in the PT world that like we debate whether or not SIJ pain is really SIJ pain or is it like L5S1 radiculopathy. But in my mind, those two things like behave very differently. And maybe that's just me. Maybe that's my bias as a pelvic floor therapist. But SIJ pain does radiate typically down the leg, which is why a lot of people think that they have like a sciatica or a lumbar radiculopathy when it's really SIJ pain. However, the big thing about SIJ pain or sacroiliac joint pain is that it doesn't go past the knee typically, right? That referral pattern, that like joint referral pattern goes down the back of the leg, but does not go past the knee. So for example, and this goes back to like just the general orthopedics, pelvic or physical therapists in us. If you were trying to figure out, what's going to centralize this person's symptoms, and the answer is neither direction, it's not flexion and it's not extension, then it's probably their SIJ, or it could at least be their SIJ, because that can also have a similar pain referral. I think the other thing, right, is that if they're not having any sort of like other nerve symptoms, say like, they're just having pain, they're not having any numbness and tingling, like maybe thinking that that is an SIJ problem as well. Because an SIJ should just be leading to pain and there shouldn't be any numbness and tingling. So that's kind of in like talking about like differential diagnoses. The thing about SIJ pain, and while we can definitely treat it as like a orthopedic physical therapist, the thing is that one of the primary stabilizers of the sacroiliac joint is the pelvic floor, right? It's pelvic floor and your transverse abdominis. If you have trouble teaching someone how to turn on both of those muscles, it's going to be hard to treat the sacroiliac joint pain. And this is just like even on top of like it's hard to sometimes diagnose, right? Even with like our little like Laslit cluster, which is like those 5 tests that to kind of rule in or rule out sacroiliac pain, we seem to still want to like treat the back and the back only, um, without like even thinking about the hips and the pelvic floor sometimes. So we're giving these people like repeated extensions and pro and press ups when really all they need in that area is stability, right? And so this is where that like I said, that patient that's coming to you with like persistent hip pain, persistent like lumbar pain, right? One of two things. You can rule in, rule out your SI pain. You can, if you're externally trained with pelvic floor or internally trained with pelvic floor, you can screen the pelvic floor. Or if you're like really lost, like it might be time to send to a pelvic floor physical therapist who is specialized in being in not only the pelvic floor muscles, but also like the diaphragm and also the like core muscles and like one of the things I think being a pelvic floor therapist made me a better orthopedic clinician was was that I could just like teach people how to turn on their core way better than when I was just like a generally trained orthopedic therapist. Um, and I think this is the other role that pelvic floor therapists have in sports med, is in these like situations where we just have a we're just it's a stubborn back pain or a stubborn hip pain. Why not bring in like the specialist, basically? Like why not bring in the person who's like specialized in this area? Um, so yeah, that's gonna be, I guess that's my other soapbox is like when in doubt, ask for help. And then that doesn't even have to just apply to pelvic health. Like if you have a patient who's not getting better, like something else, there's something you're missing. And don't be afraid to like ask for help in that situation. Um, the big kind of other component about pelvic health, not only is it sometimes uncomfortable for us to ask those conversations, which by the way, I still get uncomfortable asking some of these questions sometimes, even though I ask them every single day of my working life, right? Just takes practice. But it is also uncomfortable for athletes to talk about sometimes. And, whether we'd like to believe it or not, athletes are not going to come to us being like, hey, like, I have like pain in my testicles every time I swing a tennis racket, which, by the way, like is a real life case. Um, and that they're also probably not going to come to us being like, hey, like every time I run at the end of the race, like I leak. Because what the research has found is that while the majority of athletic people in the athletic population are going to have symptoms of pelvic floor dysfunction, they are like nearly like next to zero going to bring it up with like a coach, a doctor, an athletic provider, etc., which is why we need to be the ones comfortable asking, or we need to get comfortable asking these questions. But the other thing is that if you were leaking every single time you did your sport, whether you're a gymnast, like landing after tumbling, or you're like I said, a tennis player who every time you like swing your, like, you do any sort of rotation, you're ending up with testicular pain, you're going to be less likely to enjoy your sport, which is number one, like the most important thing, not only for performance, but also for your like own mental sanity. Um, and you're gonna like be like more socially withdrawn. You're gonna have a lot of shame like around that. You might start like skipping practice, if that's that's what you need to do, or just drop out of your sport in general. So that's why it's so important that we do ask these questions, because at the end of the day, more than just and like second to keeping our athletes healthy, we want to keep them in their sports. I feel like when I was in high school, there was like high school to college, there was a bit of a like an epidemic of like my old female teammates or current female teammates who like sports that they once loved, they were just like leaving. Um, and I don't think it necessarily in all those cases it was because of this, right? I don't like think that like, oh yeah, all of them were leaking, that's why they left their sport. But I do think it emphasizes why it's so important to be emotionally aware, to have vulnerable conversations with not only like, our athletic population, but all of our patients. Um, I love that like Lou put this like kind of comment in here, because I think I said this directly to him, but like clinicians must be able to kind of sit with their patients during vulnerable situations. And that again, that is one of the biggest barriers for people to reach um out for like support with something like this. Um is the fear of like being judged. And I, one of the first things I tell my pelvic patients, which by the way, as much as like I'm an internally trained pelvic floor physical therapist, meaning I do vaginal exams and I do rectal exams, I nearly never do them on the first visit. We just hang out that first visit. We are just chit-chatting about kind of like whatever it is that they are coming to see me. Um, because especially in pelvic floor, but again, like, with another emotionally vulnerable population, which we might not think of our athletes as an emotional vulnerable population, but they are. Um, we kind of have to just be willing to be that sounding board and sit with them through, emotional difficulties, through maybe like trauma that they've had, whether that's like physical trauma due to an injury or an emotional trauma due to like, I mean, we all hear the kind of like countless stories of like of athletes being like emotionally, physically, sexually harassed, abused, kind of like, we just sometimes think that they're tough, which they are, but we sometimes forget that they're first and foremost humans. Um, so I think with them, right, being willing to kind of just sit there and listen, and kind of tell them like, hey, we can talk about like as little or as much as you want in this arena. Um, in pelvic health, it gets a little bit more intense because my patients sometimes are survivors of like sexual assault because that is a comorbidity with pelvic floor dysfunction. Some of my patients are they have a lot of like birth trauma associated with our current medical system, which does a really poor job treating maternal patients. So again, it's not to say that like every time you see an athletic like patient, you're going to be like sitting there like, okay, I'm ready. Let's hear your trauma because that's not what this job is a lot alike, or is not like. But I think to sort of expect in your head that these tough conversations might come out, whether it's like, hey, like, every day at practice, my coach is like making comments about my body and I don't know what to do about it. Or, hey, like, I cannot stop thinking about the food that goes in my body and how it affects my performance. Or, hey, like, I have this like testicular pain and I'm having trouble being intimate like with my girlfriend. Um, those are tough conversations, right? And I think it's one of the most rewarding parts of our job is to be able to like sit there with them. But also one of the hardest, right? But that is like part of the conversation that you're welcoming when you're asking these questions, um, which can be scary. But I think like empowering yourself with the knowledge and that the hope that you can give these patients when you give them answers is both empowering, I think, for you and for the patient. And that's kind of like, I guess, that last bullet point. It's that athletes and well, all patients sometimes are coming to you just because they want someone to figure out what's going on, and they're tired of trying to figure it out for themselves. And so, you know, no matter what field you end up in, making sure that you're creating that like culture of safety, trust, and empowerment. Um, because it's hard out here, right? It's hard out here for us and it's hard out here for our patients. And being professionally vulnerable with your patients invites that like vulnerability back, which I think is a really cool thing, not only as a clinician, but also just as two humans trying to figure it all out. Um, so on that note, let's talk quickly about our pregnant and our postpartum athletes. First and foremost, was there any questions about any of that? I'll give us a sec.
I think just to reiterate the point of don't be afraid to refer out. I had, like, just for example, I had a bodybuilder who came into the clinic maybe 2, 3 years ago and didn't really know a whole lot about PT, had been training for a show and was ready to just completely drop being a bodybuilder. Because every time he would go to do particular movements, he would get what he called abdominal pain. Come to find out, it wasn't just abdominal pain. He was actually getting referral into the right testicle. And
Mm.
so he was so miserable at the fact that anytime he went to go do a deadlift, anytime he went to go brace, anything bent over rows in particular was what really set it off. And he was like, "This is who I am. I've been doing this for the last 10 years. How am I just supposed to drop this? Like this is what I am." And come to find out that like that was a part of his issue. And so I ended up actually referring him out to a pelvic floor specialist. I was like, "I don't think I'm the person to help you, but I'm glad we could at least talk about this." because he gave us like he didn't even tell his physician about that. And they were ready to almost do surgery on his abdominals, right? Like that. I was like, okay, like maybe like let's pump the brakes on that. Let's go to a pelvic floor specialist first. And he actually came in maybe I think it was over a year ago, like almost 80% better than when I had last saw him. He was like, I'm back to lifting. I jogged for the first time. I was like, this is awesome. Like this is fantastic. So it's like it's a step in the right direction. It's a process. Um, but like you already said, Adelaide, like you got to be as much as we want to be in the weeds with the science. I think sometimes we just have to be two humans coming together and try to find a resolution. It's huge.
Yeah. Yeah, I totally agree. And I think like the other thing about that like that I find when we are able to be like super vulnerable is that we're able to like fix things quicker, if that makes sense. So
Mhm.
for example, like, you know, kind of like what Lou was saying, like give like when you kind of like get these like more bits of information, they become so much easier to treat, right? And so like Lou like referring out to pelvic floor therapist, and then I get a diagnosis of like testicular pain. I was like, oh yeah, like I get like I have a handful of these on my caseload already, and it turns this like what seemingly like this really complex patient like this with this mystery pain who's seen like all these physicians, and then you just send them to the right person, and all of a sudden I'm like, yeah, just another day in the office, and they get better quicker, and they don't have to quit their sport, and they
Mhm.
um I think that's like, yeah, I think that's pretty cool, and I think that's what makes my job so cool. If I was like going to sell you on pelvic floor physical therapy, which I don't know, only if you really want to, because it is really fun. But if I was going to sell you on that, I would say like the amount of times I hear, I have seen every doctor, I've been to PT before, I've never been to pelvic floor PT, I've seen this person and that person, and no one has ever been able to touch my pain until I got to you. And I think that is the coolest. And it's all because like pelvic floor is one, an area where we can get vulnerable, and two is just such a specialized niche where we just know the ins and outs of this area differently than any other medical provider. And yeah, I just, that's like my favorite part of my job is like those patients that are like, they're like, how did you know what was going on? It's like, well, because I had like 10 other people that are just like you. And so to me, like it's another day in the office. But for someone who doesn't normally see these things, it's like this, like, oh, I can't put a finger on your pain. I have no idea. Your labs are coming up okay. This is fine. Like I can't reproduce your symptoms. Um, so yeah, that's my spiel for pelvic floor physical therapy. If you like being that person, pelvic floor physical therapy is for you.
Mhm.
All right. Well, let's touch upon pregnancy and postpartum um quickly, because I think, you could be in any setting and get a pregnant and postpartum patient. Um, whether that's like sometimes an inpatient, sometimes just in general orthopedics. Right. I've seen like a neuro pregnant postpartum patient, so like stroke plus, current pregnancy. So yeah, we can see him anywhere. And here's the thing is a lot of the common advice that we've historically given pregnant and postpartum women was professional opinion and not based in research. So again, this is that big problem that we're seeing at the moment where we're coming up with these professional opinions and we're not having the research to back it up, which is sometimes a good thing. So sometimes we're doing the right thing and then the research backs us up, and sometimes we're doing the wrong thing and the research says otherwise. Pregnancy postpartum is um, one of those areas. And I'm going to shout out my mom because she's actually on this call, but she's also a physical therapist. And I remember even from just like a really young age, she was she was telling me, she's like, I don't get why all these women stop exercising when they're pregnant. She's like, I lied on my back when I was pregnant. She was like, I was exercising the same. And she's like, and look how you turned out. And I said, I'm like, that's great, mom. And then I became a pelvic floor physical therapist and I realized she was right. And that's exactly kind of what we want to promote is we want to promote, whatever you were doing before you were pregnant, we want you to continue doing during pregnancy, with just kind of like some slight modifications, right? The big thing is that we don't want like the heart rate going up like too high. A lot of times I tell people like, the general rule is the talk test, which kind of like can encompass a lot of different things, right? As long as you're able to talk to the person next to you as you're exercising, like your heart rate's probably in a good spot. Um, Obviously, like lying on your back can be an issue. And that's like typically because that, baby is pressing on like the inferior vena cava and just affecting like kind of blood return. But that being said, it doesn't happen to everyone. So what I typically do is that like I'll like raise the head of the table a little bit if I have someone like on their back. And then I'll just tell them like, hey, if you feel dizzy, if you feel off, just let me know. And that doesn't mean that we want to like eliminate training on our back as long as we're feeling okay. It doesn't mean that we want to limit how much weight we're moving. It doesn't mean that we don't want to like get our heart rate up because we do, because that prevents, gestational diabetes and, preeclampsia and all those things. But also we can have so many benefits from continuing to move our body during pregnancy, which includes like decreased risk of complications, whether those complications are like increased risk for like cesarean section, um, likelihood of like hemorrhaging, like perineal tearing, so tearing of like the area kind of like surrounding the vagina and the rectum. So we want people to keep moving. And I think I remember being in school and even the other thing is that even if someone like wasn't moving before, that doesn't mean that they can't start moving in pregnancy. And I like, again, I remember like being in school and just walking like 7,000 steps a day during pregnancy decreases your risk for something like gestational diabetes, which I think is so cool because 7,000 steps isn't that many, right? That's like going for like a walk, just like going for a walk every day, like a stroll, like not even a long walk. And then just like continuing to move throughout the day, and you can drastically decrease your risk of like, complications. That's great. So we want people to move. We just want to be mindful of like how they're feeling. And I think that's the big thing is that if something doesn't feel right for a pregnant patient, just don't do it. Um, it kind of can be as simple as that. And then so then the other big things to think about with pregnancy is like pelvic girdle pain and then like diastasis and preventing like significant diastasis recti. The thing about diastasis recti is that 100% of pregnant people are going to get abdominal separation, right? That's just one of the reasons of like how we make room for growing a human, which, we got to do what we got to do. The thing is like making sure that it's like not significant, because obviously if it's significant, then it's harder to like harder sometimes to come back together. So, kind of the big thing, and it's not even like in the first part of pregnancy, but like just towards like the later part, I basically just limit like a quadruped position, right? Anything that's just going to put excessive strain on top of the already excessive strain on those like anterior abdominal wall on the anterior abdominal wall, right? It's just we're just going to take that out, right? So like we're limiting our quadruped, we're limiting maybe our exercises, our bent over exercises, um, right? And I would, we're just going to limit like a little bit of that excessive strain. Um, but that being said, you can still do abdominal exercises. In fact, it's encouraged, right, to continue to do abdominal exercises during pregnancy. You can still like sit up, right? Like sometimes they tell people like don't sit up when you're pregnant. Don't do a sit up. But we want that. In fact, like the way that we like return that abdominal wall together postpartum is basically like engaging the rectus abdominis. So we don't want that muscle like getting significantly weak during. Um, and we need our core to help support our pelvis. So, like I mentioned previously, the primary stabilization of the pelvic stabilization muscles of the pelvic girdle are transverse abdominis and the pelvic floor. So if we're not working our transverse abdominis, we're going to put more strain on the pelvic girdle. So, unlike what we were historically taught, pelvic girdle pain in pregnancy is not just instability. Actually, a lot of the time, what we're finding is yes, there's a laxity in the ligaments, but that is not correlated to pelvic girdle pain. What is correlated is asymmetries of the pelvis, meaning like one side of the hips is weaker or stronger than the other, one side of the pelvic floor is weaker or stronger than the other, or like, the abs aren't engaging and right. Um, so that is like why we need to keep doing abdominal stuff so we can continue to stabilize that joint. And then any sort of like asymmetries of the hip we're managing. And it typically goes away pretty easy. Like I have patients that are like being referred to me for pretty like significant like pelvic girdle pain. I give them a couple exercises and they're like all set, ready to ready to rumble. And then we get to do the fun stuff, which is like labor and delivery prep and all that good stuff. Which, as a caveat, if you are treating a pregnant patient and you have a pelvic floor colleague, after you're done treating their pain, feel free to shoot them to a pelvic floor physical therapist, just even for like a antepartum like evaluation, just so that they can get a baseline for when they come back in postpartum, which in my perfect world, every single postpartum patient, whether they had an uncomplicated delivery or a severely complicated delivery, should see a pelvic floor physical therapist during their postpartum recovery. I don't care if they like don't want to run or they don't want to like right. There are just so many significant changes in this area that left like untreated can lead to bigger problems down the line. And so, right, so not only are we looking at the muscles postpartum, we're also looking at different things like is there any scar tissue, whether that is a perineal scar. So like I said, if they have any tearing during delivery that affects their muscles and the opening of the vagina, or if they have like a cesarean scar. My professional guilty pleasure is breaking up a C-section scar tissue. The reason being is that it is hard for them to turn on their abdominals regardless, but it's even harder if they have that scar that's not moving. Um, the other thing is that if you do get a postpartum patient, ask them if they're breastfeeding. Here is why. While you still breastfeed, the estrogen in your system is still decreased. And we talked about this with ACL tears, right? If you have a decrease in estrogen, you have increased laxity of your joints, which is part of what leads to that pelvic girdle pain, which you can also get postpartum, right? And it can lead to like tissue changes around not only in the joints but also around the vagina. So this is a great example of like research finally catching up to us, but there is something called genitourinary syndrome of lactation. We knew that there was a genitourinary syndrome of menopause, but we didn't have the research really to back up like the lactation side of it. So basically what that means is that there are changes in the genitals and the urinary tract associated with the decrease in estrogen while someone breastfeeds. And that this can actually be the reason why they have pelvic pain, why their scar tissue isn't healing as well, and why that they might have urinary incontinence. So a lot of times with my postpartum patients, I'm suggesting that they talk to their doctor about some sort of like estrogen supplement for this region. All right, let's finish up this talk about like postpartum stuff with talking about return to sport, which is the fun part, right? So whether, like I said, whether they're trying to like return to lifting, whether they're trying to return to running, whether they're just trying to, keep up with their kids, maybe they have an older kid that they need to chase after, or they have a string of birthday parties with bouncy castles and they don't want to leak, right? That's another thing that they might want to get back to. Um, we need to make sure pelvic floor muscles are firing on all cylinders. Again, if you're not comfortable with that, you're referring out to a pelvic floor physical therapist. And then number two, that their abdominal muscles are firing on all cylinders so that that diastasis recti is coming within normal limits, which is about 2 centimeters. And that and then slowly starting to load them up from there. So if they're able to turn on their core muscles, we're then like adding in some gentle like table glute stuff, like glute bridges, and like clamshells and all that good stuff. And then one of my first exercises that I give my postpartum patients is single leg balance, because you won't believe how hard it is for some of these patients because their center of mass has changed so much. That and the muscles primarily, involved in like stance stability, such as like your core and your pelvic floor, have just gone through like an absolute whirlwind. So, right, that's another one of my like initial exercises is after they can kind of turn on their core, turn on their pelvic floor, I'm having them do some single leg stance exercises, progressing single leg stance from there. Once they can do single leg stance, I am starting to incorporate some hip and core strengthening and standing, whether that's a payoff press, whether that is like I love a good like single leg RDL, especially if we're going back into running, basically just like kind of building from there. Once we get to that point, right, where they can do all of those things, I'm starting to go return to jumping. And once they're being successful with return to jumping, they're not having any pain, they're not having any incontinence, they're not having like any symptoms, then and only then are they going back to running. So you can find return to sport timelines for postpartum patients. Like there's whole like research articles, but just like anything, if you just kind of follow your intuitive of like, okay, if they can activate their hips, can they activate their hips in standing? If they can activate their hips and core in standing, can they do it with weight? If they can activate their hips and core in standing with weight, can they jump? Can they jump? Can they do it multiple times? Yes, great. Then you get back to running because that's all running is. It's just jumping from one foot to the other. Um, and then when it comes to lifting, right, same thing. They're not going to be lifting even their sometimes their pregnancy weights, right, that they were lifting. So start them at something that's super attainable, even if it feels like not a lot to them. Double checking their form, right? Use all your kind of classic MSK skills. Again, let's mention psychological readiness in this population. Again, emotionally vulnerable. They might have birth trauma. They might have, like postpartum depression. Like all of these things are possible. Making sure that, and like one of the questions, I forget what the conversation I was having. Oh, I was talking to a psychologist who was working with postpartum moms, and they asked me, like, what would you ask a postpartum mom to kind of in order to determine, where they're at in their recovery psychologically? And I said, well, do you feel like you were able to bond with your baby? And I think again, that's another question we can ask, or at least get a sense of with our postpartum patients to kind of learn if like where they're at. And the reason is because if other things are going on, if other stressors are going on, whether it's postpartum anxiety, depression, psychosis, right, you name the lot, if there's something else is going on, it's going to make bonding with their child a lot harder. So, right, if they're having trouble taking care of themselves, if they're having trouble taking care of their babies, it's going to be hard to be able to push themselves in an athletic sense. So even if they are physiologically ready, making sure you're still taking the time to tick that box, right? So yeah, it's just like think about like postpartum as basically like return to sport. It's literally the same process, except you're dealing with these unique like endocrine, integumentary, reproductive concerns. But yeah, there are a lot of postpartum can be a lot of fun because yeah, it's like every sportsman's dream, which is just they just want to get people back to I feel like every sports med person I know is like, I really love an ACO because I love taking them from like this to this. And that's exactly what postpartum is. So this is like a Q and A or just kind of like, things things to start thinking about. So um Lou and I were kind of like, right, like, students, do you have any questions about like your clinical region, your language, your referral decision-making process, or like from like an athlete standpoint, like, do you have like questions about like red flags, advocating? But I mean, obviously, if there's any other kind of like questions as well, or Lou, if you have questions you have for the group as well outside of this slide.
So I guess kind of a statement when we start getting, so like even if let's say you go into athletics and you're primarily working with male athletes, that doesn't mean that this just goes off the table. I mean, these are things that we need to start making sure that in high velocity type sports, we are doing our due diligence of asking the right questions. And especially like sometimes we get like one of my biggest irritants about language is hernia, right? So we start talking about like sports hernia. It's not a true hernia. It's how do we go about educating people on that aspect of things, and how do we go about teaching them that hey, we can work on particular like dry needling is a huge thing with this. But how do we go about teaching them about what is a hernia versus the tearing of the tendon area away from the pubic symphysis, either at the rectus abdominis or with the adductors? So just because you might not be treating female athletes doesn't mean that the pelvic floor and the pelvis doesn't go off the table. We need to make sure that we're staying up to date with the current research, staying up to date with what's going to be the most effective use of our skill set to treat these types of athletes. Because, like for example, a few years ago, Notre Dame had a very fantastic wide receiver, and during one of the practices, he reached back because the ball was thrown behind him, and he caught the ball and ended up basically pulling the rectus abdominis away from the pubis. That happened with a few different wide receivers, and it will continue to happen. So being able to make sure that we are staying up to date with how do I then go about treating that. And actually, there's a great story. Adelaide, I don't know if you heard this story either. There was a patient who was actually going to have so this goes back to like the muscle referrals, but one of the patients was having a lot of testicular pain. And he had been to like you said, he had been to a few different doctors, and the doctor was ready to take that out. And Andy, one of the dry needling clinicians that I teach with, just did a few sessions with him, needled into the obliques, and the testicular pain dissipated. And he was like, "I saved that man's testicle." That's what his big claim to fame is that he did that. And it's like, but that's huge. I mean, that man could have gone through that surgery and then could have still been having that pain, and it's just gone. There's no putting that back. So. I mean, it's just good to have that information and know when to refer out and know basically what questions to ask.
Yeah. Yeah, I see, especially in like the young athletic population, I see a lot of testicular pain because people overengage their obliques, right?
Mhm.
And like basically the reasoning for that is like the, genitofemoral and like ilioinguinal nerves run right through kind of like the right between the obliques and through the inguinal canal.
Mhm.
Uh, so yeah, I see that. And a lot of times they're tennis players. I've seen like a handful of tennis players where this is the problem because of so much rotation. What question you got, Danielle?
So, just to kind of bring everything together, let's say you have a female athlete. She's involved in like a high impact sport. She's like high level sprinter or maybe even like college weightlifter or something like that, who's having pelvic floor dysfunction. And you recognize all the signs and you've done your red flag screen and everything. How do you go about like just a few maybe interventions that are geared towards pelvic floor strengthening and are also not going to like set her back, I guess, because if she's used to like high level activity or high level weightlifting, how do you make sure that you reinforce her to continue to make gains in her sport and not like give her like any fear about moving forward, but also address the pelvic floor issues? Does that make sense?
Yeah, makes
Okay.
complete sense. Um, yeah, I think this goes back to like I said, I'll bring it up again. It goes back to like, why are we running if we can't stand on one leg? And I think it's going to be a lot about like education about how, and like I remember even just like doing this as an athlete, even when it came to like, because like my event in track was ended up being like the throws, which is a really technical event. And sometimes you had to break down your form. So take like 4 steps back, at least that's what it felt like, to take like 6 steps forward or like, to kind of go forward. And I think educating that, hey, if you want to get to the next level of your sport, we need to take a step back and address the basics, right? But that being said, these muscles are going to be active when you deadlift. These muscles are going to be active when you sprint, right? These muscles are going to be active. Like a good example of this is like someone on the cheer or dance team or the gymnastics team who's tumbling. Like these muscles are going to be active with all of that. We're going to start with learning how to turn these muscles on. We're going to bring them back to the party first, and then we're going to start to integrate them with higher level activities. So, like Lou said, just like you are going to like see someone, you want to see someone deadlift, if they have pain with deadlifting, if you want to return them to an activity, you're going to want to watch them do that activity at some point in your rehab process. So, like for example, if it's a sprinter, right? Okay, great, they've learned how to turn on their pelvic floor muscles. Can they turn on their pelvic floor muscles with like a standing march? Right? Like, there's going to be steps between that, but like that's like an intermediary step that this person should be able to coordinate their abdominal and their pelvic floor with a march. And then, okay, if they can do it with a march, can they do it with like a triple extension? Can they then do it with like a hop, right? The amount of people I have like jumping and hopping with pelvic floor contractions is super high because a lot of times that's when people get their like incontinence. Then can we get you back jogging with good breathing mechanics, good pelvic floor engagement, and talking about like what that looks like? And then eventually, hey, like this is how you're going to incorporate it into your event, right? So it's a stepwise process, but right, to break it, we gotta break it down to build it back up. Does that make sense?
Yes, thank you.
Yeah, no worries.
Any other questions?
I had a question about the postpartum population in particular. I know for our case study, it was 12 weeks postpartum. And I know you said sometimes it's a chronic issue, but like when would be your ideal time frame to see them in the clinic to work with them postpartum?
My ideal time is to see them the day after they deliver. If I in my perfect world, I would be, and like what would I be doing that day would be very different than what I do, I'd say like once they're medically cleared. Um, So, right, in my ideal world, I would see them the day after delivery. I would teach them about like all the things that we do as like inpatient PTs, which is like protect the incision, learn how to like, brace their core. There's a reason why like my mom, the inpatient physical therapist, knows how to say cough in like 14 different languages because that's one of the things that we're like working on, right? How do you brace your core and cough while still protecting like your incisions, or how do we clear secretions while still protecting our incisions, or et cetera, et cetera. So what is typically happening though is that like so I can do all of that right after. And then, I still get some patients that are referred to me before 6 weeks, but I'm not doing any internal work. I want like OB clearance before I do any internal work, but I am teaching them how to turn on their abdominals. I'm doing external palpation of their pelvic floor muscles. Right. And so that's that, like, and it's like they'll get medically cleared a little bit later with a C-section, like closer to that, like 10 to 12 or 8 to 10 to 12 week, depending on like if there was complications or further complications, I should say. Um, right. And then like again, that's when I can start assessing like the pelvic floor. But at that point, right, before they're medically cleared, like I still want to make sure that they're slowly engaging their abdominal muscles, right? Not like necessarily like high level stuff, a lot of like just like mat stuff, maybe a little bit of hip strengthening. Yeah, but yeah, my perfect world is I would see them the day after.
And then Adelaide, just to kind of follow up, what would be, I guess, what are some of the more reputable courses or pathways to go through for learning pelvic floor? Or like, is there any particular groups, courses that you would recommend?
Yeah. So Lou and I work for Select Medical. Select Medical has their own courses that right now I think they're only open to employees, which I think is silly, but we'll get there.
Mhm.
Um, but basically like we have like a pelvic floor program that we have like within our company. I can't recommend it like highly enough. I think it's super comprehensive. Like the big difference between and I feel like this is like a shameless plug as well, but basically the reason why I love it so much is that you can treat all genders after the first like the level one. The kind of classic pelvic floor tracks that like people take that are maybe like less associated with a given company like ours is like your like APTA pelvic health has like a really good course. Again, you basically can only treat like couple of diagnoses within that level one course, but I think they also, I want to say that they do like an external course as well. So there's like the APTA, and then the other big one is Herman and Wallace, who, again, basically when it comes to APTA and Herman and Wallace, some people like one more than the other, but at the end of the day, it was like a whole politics thing that like one group of people like wanted to teach it this way, and the other group of people in APTA wanted to, Herman and Wallace wanted to teach it this other way. And so now they're kind of two different companies, but they cover very um, similar tracks. But that being said, um, I like even like an external course through like, any company, right? Whether it's like APTA, Herman Wallace, or if you're like a select medical employee, like I know we have like a really good external course as well. That gives you at least like a bit of extra knowledge. But then also just like finding your friendly neighborhood pelvic floor PT and picking their brain as well, just to kind of improve your awareness. But yeah, those are the big two, plus our company as well, which is obviously what I've done a lot of my continuing education through.
Awesome. Fantastic. I love to hear that.
Yeah.
In regards to any other questions, guys, this will be, I think we have one more slide, but it's really just more of like a call to action. So why don't we switch to that one here? That way you guys can kind of see. Um, these are just a few different little tidbits that I want you guys to start thinking about in regards to how we can integrate this into your screening, into your assessment, just to kind of get the wheels turning a little bit more, especially with each patient that comes in your door. Um, Being able to create that therapeutic alliance for your patients with especially your athletes if you have those different people who it is uncomfortable to ask some of these questions, but we need to be able to get every aspect of that patient in order to treat them effectively. So how can we break that, like we already have in there, breaking the stigma, and we can basically teach them and educate them without creating fear. And then basically, how can we increase our level of understanding to make sure that we as clinicians are providing, I mean, not just a great product, but treating it, from human to human. How can we just make everyone's lives better? I don't know, Adelaide, if there's anything else you want to add to that, but that's just my 10 cents.
Yeah. I think that's solid, right? I think even just having awareness of this area of the body and awareness that it's an underrepresented and under talked about area. Um, and like I think going to like Lou's point of like, yeah, these questions are uncomfortable when we're asking pelvic floor specific questions. But what's like really uncomfortable is like living in persistent pain or having like, persistent like urinary or fecal incontinence or persistent constipation or, pelvic pain or so at the end of the day, like this is healthcare. Like we do weirder things in healthcare that to help people um than just ask them about their like sexual health and their mental health and all that stuff. And yeah, I think, I think just being human to human is just like super important. And this is just like another piece of the puzzle. And arguably, in my incredibly biased opinion, one of the most important pieces of the puzzle, because what area of the body incorporates literally every single system, like the pelvic area does? Like, I can't think of one at the top of my head. Um, right? Reproductive and integumentary, like, respiratory system, the cardiovascular, lymphatic, you know, all of them are in this area. And so that's why people think this area is complicated. But I think the most simple thing is just to speak up and be willing to ask the tough questions.
Beautifully said. Any other questions, guys? All right. Well, Adelaide, thank you so much for sharing your expertise and everyone else for joining us on this wonderful Saturday morning. I hope you guys took something away from this discussion, and I'll be putting this up on Spotify. I'll be sharing it through the Lab Collective. That way, everyone can share the episode and kind of share Adelaide's expertise. And I really do appreciate you coming on here, Adelaide, and speaking with all of us because I think just after listening to how passionate you were about this up in Chicago, I'm glad that we can finally get this out because I'm pretty pumped about it.
Yeah, as am I. Like I said, this is my soapbox. This is what I stumble onto every day. So yeah, thank you so much for giving me an opportunity to speak about this and to like your students, thank you for being interested in this area because I think it's just underserved. And like I said, if you take anything from this, just yeah, just get uncomfortable. Right? Get out of your comfort zone.
Exactly. No, but guys, thank you so much. If you have any questions, feel free to reach out. And then I guess if you need anything else, just feel free to reach out to Adelaide as well.
Yeah. Lou has my email if you guys need anything.
Yes.
Thank you, Adelaide. I really appreciate you hopping on the call and answering all my questions.
Of course, Danielle, anytime.
All right, guys, and we will let you guys all go. You guys have a good, wonderful Saturday and the rest of the weekend.